The Culpeper Center was established to conduct research and provide information services to the larger community, mainly through the media, about aging issues fairly broadly. Over the past 3 or 4 years, we have narrowed the focus a bit to try to develop a sense of priority about what we're doing. We don't have infinite resources, so we have to be efficient as possible about how we use them. And over that period, we have identified long-term care and health care for older people as first priority. The second priority is retirement security, and that means primarily income support and health care. So those are our two substantive policy priorities. In achieving those, we have focused on about 3 or 4 activities. One, research. We have a major contract with the state Medicaid office to do a number of research policy analysis projects for them related to the state's long-term care program for older people. Medicaid is the principal funder for long-term care in Florida, as in all other states. And they're very much interested in trying to determine how best and most cost effectively to provide those services to a growing population of people who need them. Florida is the oldest state in the country in terms of the percentage of people over 65 and 85. That's going to be true for the next 30 or 40 years. So the need for long-term care is going to grow. And in a situation where you have limited resources, it's really important to determine how you can use them most effectively, and that's what we're set up to help the state, the legislature, the governor's office, and the Medicaid do through the contract we have with them. We're also sponsoring research with some funding we got from the legislature a couple of years ago. We have funded 5 research projects that are now underway through the efforts of 5 FSU faculty members dealing with aging issues. Everything from how to develop an elder-friendly community, how to use the Medicare data to more effectively identify cost-effective primary care interventions as well as long-term care. And we're also developing an aging almanac for Florida with our colleagues in the Pepper Institute, John Reynolds and his staff, that will pull together all of what we think are the major kinds of information that the general public might want to know about where we are as a state with an older population that both brings major benefits and also needs services. And we hope to provide probably about a 50-page almanac that will highlight all of that. Sometimes people forget that having an older population is a net benefit to the state of Florida. We estimate that for every dollar we spend on older people in terms of health and long-term care, they bring in $3 in terms of taxes, fees, and consumption. So that's why the state of Florida has really benefited from that in-migration that we've had for the last 40 years of retirees, and it we hope to maintain because it's overall a net benefit. We also, our third kind of strategy for achieving those priorities is conferences, seminars, and symposia. And this year, 2012 into next year, we're going to do 2 conferences sponsored with our colleagues in other departments in the university and with the support of the dean, David Rasmussen, who has identified aging as a priority area with us as a major resource for achieving that. We're going to have a conference on the future of long-term care. We're going to bring in about 6 speakers who are experts in this from around the country, hold it for 2 days here, probably in December, and that will help us both achieve our priority related to long-term care policy and programs, but also help us set a research agenda for the next 5 years. And then we're going to hold a second one probably January, February of 2013, and it will be on women and aging. That's an area that is receiving increasing attention, but is still largely underdeveloped. Women are at a disadvantage when it comes to income security in retirement. They make substantially less than, in terms of retirement income, than men do, and they have certain unique healthcare needs that a lot of people don't feel are being adequately met within our current healthcare system. So we plan to highlight those issues bringing in about 5 or 6 speakers. And that's a conference in February. And from time to time, we also hold seminars here to train people from the community, from the state agencies, from the university, in various technical areas related to research methodology, statistical analysis, data mining, computer work, things of that nature. And the director of the data center, Glenn Mitchell, is the one who leads most of those training seminars. So that's kind of an overview of what we are trying to do here at the center now. Older people, their unemployment rate of people over 55 is lower than for people under 25, certainly. But it has gone up a lot since the Great Recession began. But the fact is that if you're unemployed after 55 or 60, your chances of getting a new job are about half the chances for a younger person. That's new. And it's not clear exactly why that is happening, but it's creating a real hardship for a growing number of older workers. And I don't know if it's necessarily a case of discrimination or less positive attitudes about older workers. I think that a number of factors play into that. And I'm looking at them as part of the work I'm doing here on a policy paper on employment and older workers. I think a lot of it has to do with either actual or perceived cost of hiring and maintaining older workers, especially healthcare cost, pension cost, things of that nature, labor cost generally. I think that gets overplayed, but when companies are looking to save every dollar and to gain maximum efficiency in their labor practices, those kind of things can have a deleterious effect on older workers, especially in this economy. But I don't think that there's I don't think there's been a significant shift in attitudes towards older people over the last 5, 20, 50 years. I think that generally, if you look at the polls, the population that has a positive attitude towards older people, they have a positive attitude towards their parents and grandparents, and that carries over to the general population of older people, I think. If you look at support, for example, for Social Security and Medicare among the under 45, the under 30 age groups, it's as high as the population over 65. It's 75 to 80%. Support or even want increases in those programs. So I don't think there's any evidence that within the general population there has been any lessening of positive attitudes, respect and admiration for older people that's discernible at this point. I just don't think it's there. Now, I am bothered by what I hear in the media from time to time and from so-called expert pundits in the media who have this notion that maybe older people are getting more than they deserve through Social Security or Medicare. And I think they're dead wrong about that, and part of our job here is to show how wrong they are to help contain the damaging effects of that perspective. But in the general population, it's not there. Yeah, so you get a real gap, in my judgment, between the public and some of our elites, especially out of DC, kind of the Beltway consensus, that we've got to cut these programs in order to deal with the deficit. General public doesn't support that. It's harder in many ways, in part because of what I've just described as that Beltway consensus in the media that these programs are at the source of our deficit problem. We have to work here daily to make sure that a more informed perspective is brought to bear on that perception, because it's not true. Our deficit problem is fundamentally a result of 2 or 3 things. One, tax cuts in 2001, 2003, knocked about $3.5, $4 trillion off the revenues over a 10-year period. The Great Recession added about $5 trillion to the deficit, largely because of reduced revenues that came from increasing unemployment. Social Security and Medicare have played very minimal role in the current deficit. Social Security will never play a significant role in the deficit because it can't. By law, it's limited to the amount of money that comes in through the payroll tax. You can't pay benefits that exceed what's available through the payroll tax. Medicare is another issue. Medicare, over the next 30, 40 years, will contribute substantially unless we change our healthcare system to the deficit. About 75% of the deficit going forward some people think, some estimates, it's somewhere between 70 and 80%, is attributable to increasing healthcare costs impacting on the Medicare program. And that has to be addressed. We cannot afford to have continuing healthcare cost annual increases of the kind we've had for 30 or 40 years for the next 30 or 40 years. Not with the growth in the population, not with the growth in the older population. It's not just Medicare. We now spend 17.5% of our GDP on healthcare. At the rate we're going to spend 25% by 2025. That will put a great stress on the total economy. And that's not coming from Medicare, that's coming from drivers within the whole healthcare system. And we have a bigger problem with that than any other developed country by far. We spend twice as much on a per capita basis for healthcare as any other developed country. And I think it's imperative over the next few years, at least the next 10 years, that we learn as much as we can from what other countries have done to contain their costs and apply them here in whatever modified version is required given the unique American situation. But to pin all that responsibility on Medicare is, I think, both unfair and is not going to fix the problem. I mean, you can cut Medicare and offload the costs onto the older beneficiaries and actually begin to defeat the whole purpose of having a Medicare program, because the reason we have it is because in 1965, 50% of the 65 plus population had no insurance. And most of them were receiving charity care. We fixed that problem. We haven't fixed the cost problem.